everyone, Assalamu alaikum. This is Dr. Tazeen, and I'm here with RRR Series for you as your exam is just around the corner. So I hope this will help you. So if you have not subscribed the YouTube channel of Study Medic, subscribe now and then click on the bell icon so that you can get an idea about the new upcoming series. So in this topic, we are going to discuss about high performance liquid chromatography, hemoglobin electrophoresis, as well as laparoscopy. I will give you an idea that how the exam tested questions can be there in the exam. Before start of session, remember one thing, that your passion and dedication is the key to success. All this hustle which you have done is the antidote to all your problems, so that you have to remember. All right. So first of all, to get an idea that what high performance liquid chromatography is and what is hemoglobin electrophoresis, basically high performance liquid chromatography is a highly sensitive analytical technique which is used to separate, identify, and quantify components in a mixture. It is widely used in clinical, pharmaceutical, and environmental fields. And it is basically used for the hemoglobin analysis. It is used to identify various hemoglobin variants and to diagnose hemoglobinopathies. For example, sickle cell anemia, thalassemia. It can separate the different hemoglobin types based upon their retention times in a column under controlled conditions. So the conditions are controlled, and then all the different variants of hemoglobin, they can separate and they can be analyzed by using high performance liquid chromatography. There are various types of hemoglobin. As we know, normally hemoglobin A is 95 to 98%, which is the major adult hemoglobin. Hemoglobin A2 is up till 3.5%, which can be elevated in beta thalassemias. And hemoglobin F is less than 1 to 2% normally, and it is elevated in hereditary persistence of fetal hemoglobin or beta thalassemia major. So here you can see that when this liquid high performance liquids chromatography is performed, there are various strains of different types of hemoglobin. They separate, and basically we are analyzing it at two different pH, that can be alkaline or that can be acidic. The first thing which we should know is that we should know that which pH it is. It can be 6 or it can be 8. Okay, and depending upon that, we can identify that which hemoglobin variant is this. So here basically you can see that pH 6 is used as hemoglobin. It is negatively charged particle, so it will move towards the other particle. Okay, and then these different variants, they will be uh, you can say that on the strips, they will be identified as different variants depending upon their migration. Okay, so here you can see that this is known as this is normal chromatography, where the prominent S and faint F band are there, okay, near the cathode, and therefore it means that the pH which was used was 6. Okay, so you can remember that here that CSAF, that hemoglobin CS, then A and F, that is the pattern of migration which is used at pH 6, that indicates that the unknown sample to localize with the A band on citrate agar. Therefore, they must be normal from the choices. There can be abnormal findings and there can be various interpretations of this. Beta thalassemia trait, hemoglobin A2 is more than 3.5%. Okay, hemoglobin F normally or slightly raised, and hemoglobin A normally or mildly reduced in beta thalassemia trait. In beta thalassemia major, hemoglobin A is absent, as this is a major hemoglobinopathy. Hemoglobin F would be markedly raised, that can be more than 90%, and hemoglobin A2 normally or slightly increased. Then there comes sickle cell trait and sickle cell disease. In sickle cell trait, hemoglobin A is 50 to 60%, hemoglobin S is 35 to 45%, hemoglobin A2 is normal, and hemoglobin F is normal or slightly increased. And here you can see that you can see two peaks. One is at the level of hemoglobin A, and then another one is at the level of hemoglobin S. Okay, so this is sickle cell trait, while in sickle cell disease, you can see only one peak that is at the level of hemoglobin S. So sickle cell disease is basically hemoglobin S is more than 80 to 90%. Hemoglobin F is variable, hemoglobin A is absent, okay, and hemoglobin A2 is normally or mildly raised, which you can see here. Okay, so then moving forward is hemoglobin D and hemoglobin S, which can be abnormal findings that how we have to find out. So hemoglobin D and hemoglobin C will have distinct peaks on the liquid chromatography, and interpretation is that in the trait it would be 60 to 70% hemoglobin A and 30 to 40% would be abnormal hemoglobin, and mainly in the diseased state abnormal hemoglobin would be main, and hemoglobin A can be absent, or it can be absent, or it can be in very low quantities, which you can see that here is the disease. So in the diseased form, hemoglobin A would be very, very low, or hemoglobin A can be absent. And in case of trait, you can see that 60 to 70% is hemoglobin A. So you can see that the peak is there. And also there is 30 to 40% abnormal hemoglobin C is there. So that is how you can, if you are getting the images in your exam, you can identify in that way. The advantages of high performance liquid chromatography are that they are highly sensitive, the accurate quantification of hemoglobin fractions and various variants can be carried out automated and reproducible for clinical settings. A blood sample is processed to isolated hemoglobin. The sample is injected into this system, which is high performance liquid chromatography. Hemoglobin components are separated based upon their interactions with the stationary phase in the column, and a detector quantifies and identifies the various hemoglobin variants. Then hemoglobin electrophoresis is basically a laboratory technique which is used to separate hemoglobin types based upon their charge and mobility in an electric field. It is a classic method for detecting the hemoglobinopathies. It is basically for the identification of abnormal hemoglobins like hemoglobin S, hemoglobin C, and hemoglobin E. So differentiated of it is the differentiation of common and rare hemoglobin variants. Advantages of hemoglobin electrophoresis is that it is simple and cost effective, suitable and rapid screening in low source settings. So if we compare high performance liquid chromatography and hemoglobin electrophoresis, it is basically caused by separation of retention time in column by in the liquid chromatography, and in electrophoresis it is separation by charge. So the charge is basically how the hemoglobin is migrating from one charged particle to other is electrophoresis, and when there is separation by retention time in a column, that is liquid chromatography. Liquid chromatography is highly sensitive, while hemoglobin electrophoresis is moderately sensitive. It is fully automated when we talk about liquid chromatography, while electrophoresis can be manual or semi-automated. And it gives high throughput, and while uh, electrophoresis that is giving us low to moderate. Liquid chromatography is expensive, while electrophoresis is cost effective, and liquid chromatography is basically used clinically in detailed quantification of hemoglobin variants, whereas hemoglobin electrophoresis that is used for screening and preliminary diagnosis. So hemoglobin electrophoresis is basically again a laboratory technique which is used, as we know, various variants of hemoglobin for identification of abnormal hemoglobins, for differentiation of rare types of hemoglobins. It is simple, cost effective, suitable, and rapid screening in low source settings can be done. So again, various types of hemoglobin and how they migrate on the in electrophoresis. Hemoglobin A is 95 to 98%. It is farthest towards the cathode. So that is the migration behavior, that it will be farthest towards the cathode. A2 is 2 to 3%. It would be behind hemoglobin A. Hemoglobin F is 0.8 to 2%. It is less forward towards the cathode. Hemoglobin S is normally absent, C is absent, and E, H, and M, they are variable and they are basically specific to certain conditions. So here now you can see the migration pattern of hemoglobin when we say that hemoglobin A and we say that it is farthest towards the cathode. Here you can see that this is hemoglobin A, and it is also in 95 to 98%. You can see that it is shown in higher quantity. Then hemoglobin A2 is behind hemoglobin A, okay, 2 to 3%. Hemoglobin F is 0.8 to 2%. You can see that small quantity of hemoglobin A2 is there, okay, in the normal variants, and then hemoglobin F 0.5, 0.8 to 2%. So whenever there would be some problem that if the hemoglobin A quantities are less, hemoglobin A2 levels are raised, hemoglobin F is present in highest quantities, as we can see that in thalassemia major, hemoglobin F is present in higher quantity. So we would be able to understand that, okay, this can be beta thalassemia major. Hemoglobin A2 is also raised, as normally we know that this thin line indicates that it is present in very small quantities, and this thick line is showing that, okay, from the normal variant, it has increased. So there can be some problem. How to differentiate between beta thalassemia trait and beta thalassemia major? That hemoglobin F is in raised quantities in case of beta thalassemia major. When you have a look at the beta thalassemia trait, it is present in minor quantities. So this is how you can be able to understand. In case of sickle cell trait, you can see that hemoglobin S is present, and in case of sickle cell anemia, hemoglobin S is present in higher quantities. So, and hemoglobin F is also present while hemoglobin A is absent. So you can identify that, okay, this can be sickle cell anemia, and this is how you have to identify the various types. The migration pattern of hemoglobin varies depending upon the pH of the electrophoresis medium, because hemoglobin differs in net charge at different pH levels, and there are two types of hemoglobin electrophoresis which are being used. One is being used alkaline electrophoresis, which we have to remember the pH, and one is being used as acidic electrophoresis, where the pH is acidic. The medium used is cellulose acetate. Direction is that hemoglobin migrates towards the anode, okay, and migration speed will depend, further we will be able to identify that how the hemoglobin is migrating. So here we can see that hemoglobin A is normal adult hemoglobin. Hemoglobin F is fetal hemoglobin, which is seen in thalassemia major. Okay. And hemoglobin S is present in sickle cell disease. Hemoglobin D is basically normally not present. Hemoglobin G is hemoglobin G Philadelphia. Hemoglobin C is slowest. Hemoglobin E co-migrates with hemoglobin A2 and C. So at alkaline pH, some variants co-migrate like hemoglobin S, hemoglobin D, hemoglobin G, hemoglobin C, E, and A2. So acid electrophoresis is needed to differentiate these. Hemoglobin electrophoresis is basically used to diagnose various hemoglobinopathies such as sickle cell disease and thalassemia. When we are using the acidic electrophoresis, that is the pH is 6 to 6.2, citrate agar is used, and hemoglobin migrate based upon the different charges from those at the alkaline pH. So farthest would be hemoglobin C, and close to the origin would be hemoglobin F. So based upon their migration pattern, basically this is how the hemoglobinopathies are being identified. And in the most exam tested area in your exam question, that is which you have to remember, this diagram is very, very important as far as exam is concerned. And you should be able to identify that if it is a normal pattern, if it is beta thalassemia trait, if it is beta thalassemia major, if it is sickle cell trait, and if it is sickle cell anemia. So you should be able to identify. But the background knowledge of hemoglobin electrophoresis, how it is performed, what are acid electrophoresis, what is meant by alkaline electrophoresis, you should be able to identify. That is basically depending upon the migration pattern of hemoglobin in various medias. So from the cathode to anode, the migration pattern would define that which one, how you can identify the various hemoglobinopathies. And this is basically the summary of acid versus alkaline electrophoresis, that in case of acidic, hemoglobin F is slowest and hemoglobin C is fastest on the migration pattern. So S and D now separate, and C and E also migrate differently. While in case of alkaline, hemoglobin A is fastest and hemoglobin A2, E and C, they are slowest, which you should be able to identify while you are provided the diagram. So acid electrophoresis is basically citrate agar is used, and hemoglobin basically migrate based upon different charges from those at the alkaline pH. Okay, so what we have to actually remember is that in the liquid chromatography as well as in the electrophoresis, we are basically using it to identify the various variants. And in electrophoresis, depending upon the migration of various variants, we will be able to identify that which type of hemoglobin is, and hemoglobinopathies can be identified by this. So we should be knowing that what are the normal values, which we should know so that we can identify the abnormal values. All right. So then moving forward to laparoscopy, basically the initial pressure in laparoscopy, we know that laparoscopy is minimally invasive surgery which can be used in various gynecological procedures being in gynae, and they can also be used for non-gynecological procedures as well. The initial insufflation pressure is 10 to 15. Okay, during carbon dioxide insufflation, it helps to create pneumoperitoneum safely for trocar insertion. The safe entry pressure limits in the non-pregnant is up to 15, and while in pregnancy, it is considered to be 10 to 12 millimeter of mercury to avoid uterine compression and reducing the venous return. So then how the exam question can be asked in the exam, and how we can apply, our knowledge in the exam by keeping in mind the key areas. Here the exam question says that which of the following statement regarding laparoscopic entry in cases of previous abdominal surgery is false. In patients with previous abdominal surgery with midline scar, the open entry incision can be placed well lateral to the midline and beyond the lateral border of the rectus muscle. Option B says that infra-umbilical close entry technique should not be used in patients with previous abdominal surgery. Option C says that infra-umbilical close entry techniques are very safe in patients with previous transverse suprapubic incisions, as there is negligible risk of periumbilical adhesions. Open entry techniques like the Hessen's method are definitely preferred for thin patients, and Palmer entry point is unsafe for patients with previous splenectomy. So here the correct answer is C, that infra-umbilical close entry techniques are very safe in patients with previous transverse suprapubic incisions, as there is negligible risk of periumbilical adhesions. So what is the basically concept behind that? That high risk of bowel being densely adherent to the underside of the midline incision, close entry technique can be used in women with a midline scar. If it is there, that can be associated with risk of complications that can lead to bowel injury if the adhesions are there. So that is absolutely contraindicated. Palmar point is situated in the left mid-clavicular plane, 2 to 3 centimeter below the costal margin. This is your exam question, that where the Palmar point is. Number one, you have to remember that it is on the left side, 2 to 3 centimeter below the costal margin in the mid-clavicular plane. So mid-clavicular plane, left side, 2 to 3 centimeter below the costal margin. We know that left upper quadrant is the area where the adhesions are least likely, but somehow there can be adhesions if the patient had splenectomy. So if they have given you a scenario that patient had splenectomy, then in that situation, you should be aware that Palmar point entry won't be a suitable option if the patient had surgery in that area, as you can expect adhesions in that case. In the presence of a midline laparotomy scar, the open entry incision can be placed well lateral to the midline and beyond the lateral border of the rectus muscle. This minimizes the risk of encountering bowel adherent to the midline scar and avoids having to cut through the bulk of the rectus muscle and potentially damaging the epigastric blood vessels. Then another exam question can be asked about the pressures. At what pressure should the pneumoperitoneum be maintained during the insertion of a secondary port for laparoscopic procedures? 5 to 10, 12 to 15, 20 to 25, 30 to 35, more than 35. And the answer is 20 to 25. Secondary ports must be inserted, number one, under direct vision, perpendicular to the skin, while maintaining the pneumoperitoneum at 20 to 25 millimeters of mercury. So that is something which you have to remember. Another question, that 19-year-old woman is to undergo laparoscopic for pelvic pain. Which would you describe the correct technique for entry with the varus needle? All the exam tested areas, basically they revolve either around the complications of laparoscopy, that what can be the common complications, or about the entry techniques, which that how you will be how which is the suitable entry technique, and what the pressures to be maintained. So you should be well aware about that. That enter below the umbilicus horizontally and then pass the needle at 45 to the skin. Enter below the umbilicus transverse plane and then pass the needle at 45 degrees to the skin. Enter below the umbilicus vertical to the skin. Enter at the base of the umbilicus and pass the needle at 60 degrees to the skin, and enter the base of the umbilicus vertical to the skin. So basically we entering the umbilicus vertical to the skin. In most circumstances, the primary incision for laparoscopy should be vertical from the base of the umbilicus. Care should be taken not to incise so deeply as to enter the peritoneal cavity. The varus needle should be sharp with a good and tested spring action. A disposable needle is recommended. The operating table should be horizontal, not in the Trendelenburg tilt. At the start of the procedure, the abdomen should be palpated to check for any masses and for the position of the aorta for insertion of the varus needle, as there can be major vessel injury if the patient is very thin, then aorta is just 2 to 3 centimeter from the skin, so that can be something that we can end up in major vessel injury. The lower abdominal wall should be stabilized in such a way that the varus needle can be inserted at right angle to the skin and should be pushed sufficient enough to penetrate the fascia, and two audible clicks are usually heard as these layers are penetrated. One is the rectus sheath and the other is peritoneum. So two audible clicks when we are inserting the varus needle, two audible clicks are basically here. So this is, you can see the varus needle, the liver is there, then fixator ring is there, flexor is there, grip is there. Okay, this is the cannula and that is the inner stellate. So varus needle, it is also disposable varus needle is also available, which is recommended nowadays, but the spring action of the needle that should be assessed before entering and before starting the surgery. Entry technique for the varus needle, the common techniques for creating peritoneum, usually inserted at the umbilicus at 45 degrees in non-obese, 90 degrees in the obese. So the placement is confirmed by the saline drop test, aspiration test, or insufflation pressure less than 10 millimeter of mercury initially is maintained, and the complications which can be associated are bowel and vascular injuries which are there. So if somehow the routine technique is not possible due to some risk factors which can be associated, then open Hessian technique or Palmer entry point can be used. So open Hessian technique is basically direct entry under direct vision. It is preferred in previous surgeries or wherever the risk of adhesion it is there, and Palmer's entry point is used, which is, as I discussed, which is also exam tested area, that 3 centimeter below the left costal margin in the mid clavicular plane, and it is used if the umbilical access is contraindicated, and on entry, a panoramic view to identify any pathology is taken. So whenever we are inserting the laparoscope, the first thing which we have to do is to take a panoramic view of the peritoneal cavity. What is the significance of that panoramic view? That if any unexpected pathology is there, if we are expecting adhesions, if some mass is there, so that is very, very important to identify that how is the pathology, how we can identify how to go about for the surgery. For example, this diagram can be there in the exam. You can see just the chords of the violin, they are there. So this is basically Fitzhugh-Curtis syndrome, which is basically perihepatic adhesions. which can be a complication of pelvic inflammatory disease, that the adhesions are there, inflammation of the hepatic capsule and diaphragm, pleuritic chest pain can be there, or it can be patient can have symptoms, or there are no signs and symptoms of pelvic inflammatory disease, but that this fits her Curtis syndrome is exam tested area, that the diagram image can be there, and you have to identify that what it is. Then internal iliac, how to identify the internal iliac artery if you are doing a surgery. So there are certain landmarks which we have to identify, that it is a branch of common iliac artery. It runs medially and inferiorly into the pelvis, lies medial to the external iliac artery. And the key landmark during pelvic surgery, it is that we have to avoid injury to the internal iliac artery, and also this artery is ligated for the management of postpartum hemorrhage. So we should be able to identify it. It lies near the ureter, so we should be very cautious while dissecting the ureter, and it bifurcates into anterior and posterior divisions. So careful dissection and anatomical knowledge is very, very important to avoid the complications during advanced laparoscopic procedures. So, and then another important aspect is laparoscopy in pregnancy. Whether we can go for laparoscopy in pregnancy or not, laparoscopy can be done in pregnancy. It is as safe as that is in the non-pregnant state. The safe time is the second trimester, 14 to 20 weeks. However, if the situation is there that we have to go for laparoscopy, that can also be performed in the first or the third trimester if it is urgently indicated. The indications can be that if it is suspected appendicitis, adnexal torsion is there, ectopic pregnancy, cholecystitis, or persistent ovarian cyst if it is there. So the precautions are that we should avoid injury to the uterus. Okay. So open Hesson technique or the Palmer point entry technique should be used. Sufflation pressure should be maintained low at 10 to 12 millimeters of mercury. Left lateral tilt should be used to avoid aortocaval compression, and continuous fetal monitoring pre-operatively and post-operatively should be carried out while performing laparoscopy. If the mother is unstable or the baby is having distress, then it should not be performed. And if the extensive uterine size making the access difficult, then also it should not be considered. General anesthesia is standard, and short acting agents should be used, as we have to avoid carbon dioxide accumulation. And post-operatively, baby should be monitored for the fetal well-being, and thromboprophylaxis should be provided due to increased risk of venous thromboembolism. So then another exam tested area, that on deciding where to place your secondary lateral ports at laparoscopy, care should be taken to avoid the inferior epigastric vessels. So where these vessels can be found 2 centimeter from the midline, lateral to the lateral umbilical ligament, lateral to the medial umbilical ligament, medial to the lateral umbilical ligament, medial to the medial umbilical ligament, and they are found lateral to the lateral umbilical ligament. The deep epigastric arteries and the vena comittantes running beside them can be visualized just lateral to the lateral umbilical ligament. The obliterated hypogastric arteries in and all, but in all the obese patients. So this was all about the laparoscopic exam tested areas and about the electrophoresis and chromatography, which is making you worried. So I hope this will be clear for you. We wish you all the very best for your exam. We know that you are going to do great, and success will be yours. So with all the prayers and best wishes, Study Medic wishes you all the very best for your exam. Thank you so much.